this is a figure from the paper, which again shows accountable justification compared to the controls and peer comparisons. And again, suggested alternatives didn't meet the pre-specified significance. Jeff Gerber wrote the editorial for this, and as some of you know, Jeff has done a lot of work using the EHR as a way to try and improve antimicrobial stewardship. He's looked at things like audit and feedback, and he notes a number of things. One, again, that changing clinician behavior is challenging, and he mentions you can use public health education programs, but they're expensive, they're time consuming. He also notes that when you survey pediatricians and internists and you ask them, they all agree that antimicrobial resistance is an issue and that antibiotics are overprescribed, but not in their practice. So I think, again, that kind of gets at some of the things we heard about earlier this afternoon in terms of education and sort of providing data and trying to provide data immediately, which, again, it has been raised this afternoon. Jeff notes that the widespread use of the electronic health record does allow for this type of approach, and he mentions the need for more national database and benchmarks to kind of help this process. This next paper is a descriptive paper, and this is from our friends at the CDC, and the names will be, the names are well known to all of us. This is basically a snapshot of where we are nationally with stewardship. This is antibiotic stewardship programs in the U.S. acute care hospitals from the 2014 National Health Safety Network annual hospital survey, and this was published in Clinical Infectious Diseases. And I think everyone in this room understands the role of stewardship in terms of helping improve appropriate prescribing, but where are we nationally in terms of formal stewardship programs? So in 2014, there were 4,184 U.S. hospitals that answered this survey. So it was a very large portion of hospitals. And overall, 39% had programs that met all 7 core components. And implementation varied. It varied by geography, it varied by size of the hospital. Among hospitals with more than 200 beds, the rates were 59%. And in smaller hospitals of 50 beds, it was only 25%. And the portion of hospitals that had stewardship programs in different states that met all these core components varied a lot too, all the way from 7%, that was in Vermont, to 58%, which was in California. And this might be a little hard to read. This is one of the tables from the article, and I just highlighted 3 items that kind of stood out to me. This is a list of the 7 core components and the various subcomponents, and I've highlighted salary support, physician leadership, as well as the need for documentation for indication as areas that looked particularly low to me, and they are perhaps areas where efforts and resources may or may not be placed in the future. The last paper on stewardship is this one from Tom Sandora from Boston Children's. This is National Variability and Appropriateness of Surgical Antibiotic Prophylaxis in U.S. Children's Hospitals, and this was published in JAMA Pediatrics earlier this year. And just like in adults, appropriate use of antibiotic prophylaxis can reduce surgical site infection rates in children, but inappropriate use has a lot of negative consequences. This was a retrospective cohort study of 31 freestanding children's hospitals, and they looked at rates of use, they looked at appropriateness, as well as adverse events. And they determined appropriateness based on consensus statements and guidelines. One of the things I love about this study is how they looked at adverse events, which they looked for children who had developed C. difficile infection, and they also looked at children who received epinephrine as a marker for a serious allergic reaction. And again, the appropriate use ranged a lot, and it varied a lot by procedure. Overall, the hospitals did quite well when prophylaxis was indicated. In fact, the median rate was 94% in terms of giving an antibiotic when one was necessary or when one was appropriate. When prophylaxis was not indicated, they didn't do quite as well. Only 52% of the time was the antibiotic not given in those scenarios. And again, not surprisingly, that the risk of adverse events was quite high in terms of the kids who got antibiotics, and the odds of C. diff was odds ratio was 3.3, receipt of epinephrine was an odds ratio of 2. And again, a good number of those kids